In this section, we will be talking about incisions and closures. Here's an outline of the subjects we will be talking about during this presentation. An understanding of basic wound healing, scalp anatomy, and principles of reconstructive surgery are helpful in order to achieve consistent and well-healed wounds. There are three distinct yet overlapping phases of wound healing: the inflammatory, proliferative, and remodeling or maturation phases, with some authors including hemostasis as the initial phase. In reality, all the phases overlap, but division of this complex process into distinct phases is helpful for ease of understanding. The healing process begins with some form of physical injury, which initiates a nonspecific inflammatory response within the local tissue, starting with hemostasis. This initial trauma also leads to vasoconstriction of local vessels, and the clotting cascade is activated, and through the production of platelets creates a blood clot. This biodynamic clot provides a link between hemostasis and the initial inflammatory phase of wound healing through its interaction with various proteins that I'll talk about later. Activation of platelets is then followed by an influx of inflammatory cells, typically within the first 1 to 2 days, initiating the inflammatory phase. Neutrophils are the first to arrive and are the predominant cell type in this phase. Their role is in phagocytosis of invading bacteria and serve to stabilize the wound bed. Monocytes follow the arrival of the neutrophils, typically 2 to 3 days after the initial tissue damage, and are activated into tissue macrophages, which are responsible for further phagocytosis and also secrete additional cytokines and growth factors that promote fibroblast proliferation, angiogenesis, and keratinocyte migration. Here's a nice table adapted from Janis and Harrison summarizing the inflammatory cytokines involved with wound healing, noting their cells of origin, their role in the inflammatory response, and their clinical application. This is a summary slide of the inflammatory phase again, showing how bacterial and other pathogens enter the wound. Platelets form a clot and release blood clotting proteins at the wound site. Mast cells release factors that mediate vasoconstriction to help stop bleeding. Neutrophils and macrophages then arrive and phagocytize the pathogens. The macrophages again secrete cytokines that attract more immune system cells to the site for tissue repair. The inflammatory response continues until the foreign material is eliminated and the wound is repaired. The next stage of wound healing is proliferation, which starts by day 3 to 5 after initial tissue injury. Timing of the proliferative phase is marked by the presence of local fibroblasts, which proliferate in the wound and become the dominant cell type by this period. Fibroblasts are responsible for the production and organization of extracellular matrix. Angiogenesis is another feature of the proliferative phase, which involves the formation of endothelium from pre-existing vessels with the help of VEGF. This is distinguished from vasculogenesis, which relates to de novo vessel formation. Wound reepithelialization is accomplished by the actions of basal keratinocytes found at either the edges of the wound or along deeper epidermal appendages, such as hair follicles, sweat, and sebaceous glands. The next phase of wound healing, the maturation or remodeling phase, involves the reorganization of collagen fibers over time. Initially, fibroblasts increase collagen production per cell. This early type 3 collagen is thinner than mature collagen, and with time, more organized type 1 collagen predominates. Closed incisional wounds regain approximately 20% of their strength at 3 weeks, 60% of their initial strength at 6 weeks, and will ultimately regain 80% of their pre-injury strength at 3 months. However, it will never reach 100% of its pre-injury strength. There are certain conditions that can impair wound healing. In general, a wound can be considered chronic if it does not heal within 4 weeks. The conditions that can impair wound healing include radiation, which produces problems with blood flow and impairs fibroblasts and wound contraction. Limiting radiation field or brachytherapy when possible can help reduce the extent of radiation damage to surrounding tissues. Aging skin, particularly in patients over the age of 65 years, have thinner dermis and are more delicate and prone to tearing than with younger patients. Smoking is well known to impair wound healing through the vasoconstrictive and prothrombotic effects of nicotine, as well as carbon monoxide reducing oxygen delivery to the wound bed. Diabetes is another well-known factor to impair wound healing as it affects the body on a systemic level. Diabetics are found to have impaired blood flow in both the micro and macro vasculature. Reduced blood flow, hyperglycemia, and derangement of the immune system make patients with diabetes more prone to post-op infections, and glucose levels greater than 180 milligrams per deciliter have been shown to associate with worse outcomes in terms of wound healing. There are some vitamins and micronutrients, such as vitamin C, vitamin A, zinc, and magnesium, that have been shown to have some beneficial effect on wound healing. It is important to try to nutritionally optimize patients as much as possible before and after surgery. Obtaining a baseline prealbumin or albumin can help identify those who are at greater risk for wound breakdown, and a nutrition consult may be helpful. And when possible, avoiding certain drugs like steroids is helpful in reducing wound healing complications. Here is a patient with a history of anterior fossa tumor with titanium mesh reconstruction and a history of radiation with residual radiation changes to the skin, as can be seen here, showing this hyperpigmented ischemic area with some superficial ulceration. While adult healing always involves scar formation, fetuses can regenerate lost or damaged tissue before 24 weeks of gestational life. Essentially, fetal skin can heal without forming a scar. The mechanisms behind this are not well elucidated, but it has been a major focus of active study recently. The benefit and use of antimicrobials in preventing wound infection has been a controversial subject for years. Tissue infection is defined as greater than 10 to the 5th colony-forming units per gram of tissue. The indications for antibiotics are within 3 hours of trauma for a contaminated wound. For clean wounds, the current guidelines advise administering antibiotics with 1 hour before incision and 24 hours after surgery. The guidelines also state that hair should not be removed unless it interferes with the surgical procedure. Shaving should be avoided due to greater infection risk, and clippers or depilatory agent should be used instead. Now moving on to the anatomy of the scalp. The scalp is composed of 5 layers: skin, subcutaneous tissue, the galea, aponeurosis, loose areolar tissue, and pericranium. The outer 3 layers, the skin, subcutaneous tissue, and the galea, remain tightly fixed together as a unit, separated from the pericranium from an avascular plane of the loose areolar tissue. And here you can see how the scalp vessels travel within the subcutaneous layer, just superficial to the galea. The scalp has a rich vascular plexus supplied by branches of the internal and external carotid arteries. The blood supplied to the forehead and anterior scalp comes from the supraorbital and supratrochlear arteries, which are terminal branches of the internal carotid arteries. The lateral and posterior aspects of the scalp are supplied by the superficial temporal artery, the posterior auricular artery, and the occipital arteries, which are branches of the external carotid artery. As you can see, there is extensive interconnection among the scalp vasculature, and replantation of the entire scalp based on a single donor vessel has been performed. The galea is the aponeurotic layer that connects the frontalis muscle of the forehead to the occipitalis muscle of the posterior head. It is contiguous with the temporal parietal fascia laterally. The anatomy of the lateral scalp surrounding the temporalis muscle is more complex. Under the skin and subcutaneous tissue laterally, the temporal parietal fascia is a thin, highly vascular layer, synonymous with the galea. The superficial temporal artery and vein are housed within the fascia, rendering this layer very influential to the viability of the laterally based scalp flaps. The superficial temporal fascia is contiguous with the periosteum of the zygoma and inferiorly with the superficial musculoaponeurotic layer, or SMAS, of the face. In this area, the temporoparietal fascia becomes adherent to the underlying subgaleal fascia, which can impede easy dissection in the loose areolar plane. However, the subgaleal fascia can relatively be easily separated from the deep temporalis fascia, a thick fascial layer also known as the temporalis fascia that overlies the temporalis muscle. The angiosome concept refers to how the body is composed of three-dimensional blocks of tissue or vascular territory supplied by specific source arteries. The source arteries may be musculocutaneous, subcutaneous, or fasciocutaneous. This concept is important when planning your incisions and flap design. Again, here is a picture of a cadaver lead oxide arterial study of angiosomes by Houseman and Taylor. You can see the vascular territories of the occipital, superficial temporal, and ophthalmic arteries here. Now on to wound closure and scalp reconstruction. As a general rule, all skin incisions are optimally placed parallel to skin tension lines, sometimes referred to as Langer's lines. You can see that Langer's lines in the scalp are directed circumferentially along the occiput and temporal parietal regions and anterior-posteriorly directed on the vertex of the scalp. This helps with ease of closure and minimizes tensions along the closure. For most incisions on the body, the scalpel should be held perfectly perpendicular to the skin to avoid obliquely undermining the adjacent dermis. However, in the scalp, modification of technique is beneficial related to the presence of hair-bearing tissue. Therefore, in the scalp, a slightly angled incision approximately 10 degrees off perpendicular and parallel to the hair angulation is preferred in order to avoid damaging the hair follicles. Damage to the follicle bulb can lead to alopecia. The forehead is the most aesthetically sensitive area and is made up of distinct aesthetic subunits, which should also be considered in planning an incision across the forehead. There are a number of classification schemes, most of which break the eyebrows into unique subunits and then break up the forehead into vertical bands, described as paramedian lateral and lateral temporal subunits. The hair-bearing scalp is a separate, distinct subunit. Standard reconstructive principles advocate the replacement of an entire aesthetic subunit when 50% or more of the subunit is altered to avoid a patchwork appearance. This results when only a portion of an aesthetic unit is replaced. The use of a coronal incision for craniotomy access for anterior lesions provides good exposure and cosmetic result as it preserves all the aesthetic units of the forehead. For the optimal aesthetic result, the authors have been placing the coronal incision farther posterior on the head, behind the scalp vertex. This accounts for future hair loss, especially in male patients, and also falls more naturally under the overlying hair, as you can see here. The classic subtemporal craniotomy utilizes a horseshoe-shaped flap to approach tentorial, clivus, and basilar artery lesions. It is based primarily upon the superficial temporal artery and secondarily on the posterior auricular artery. Preserving these arteries preserves the rich vascular supply to this flap. When addressing closure of a wound, the surgeon should consider options as depicted in the reconstructive ladder. The reconstructive ladder offers this systematic approach to increasingly complex wound closure techniques. The defect size, neurovascular anatomy, and quality of the surrounding tissue may limit the options for reconstruction. Important considerations include the size of the defect, the specific tissues missing like bone, pericranium, galea, and skin, the state of the surrounding tissue, is it contaminated, radiated, and the underlying health and surgical tolerance of the patient. The simplest method of closing a wound is by secondary intention, or allowing the defect to close and contract on its own. These wounds are typically treated with moist dressings changed once or twice per day. Here is a picture of a 72-year-old man with a clean healing granulating wound in his left thigh following dehiscence after a gracilis flap to cover an exposed vascular graft. This may be preferred over primary closure in contaminated wounds or patients who are high risk and medically complex. Moving up the ladder, management of a simple, clean incision is best achieved with primary closure, with the goal being to obliterate potential dead space, distribute tension evenly along deep suture lines, and maintain suture tensile strength until tissue tensile strength is adequate. Tension-free closure is ideal for optimal healing of a wound in terms of both complications and cosmesis. In general, scalp defects up to 9 centimeters squared can be closed primarily, but may require significant undermining in the avascular subgaleal plane to achieve tissue mobility and lower the tension on the wound. Another early step on the reconstructive ladder is autologous skin graft. Skin grafts can be easily harvested from other sites on the patient's body. Skin grafts have the advantage in that a large amount of the graft may be harvested and donor sites will re-epithelialize and heal on their own. Skin grafts, however, have significant limitation. They depend on nutrients diffusing from viable underlying tissue during the initial phase of healing, a process known as imbibition. Therefore, a healthy layer of pericranium must remain intact for a skin graft to survive. Some have had success with burning down the outer table of the calvarium to bleeding bone, restoring granulation tissue with a period of vacuum assistance closure or continuous moist dressings, and then placing a skin graft on this granulation tissue. However, this is not the most durable type of closure. Any skin graft, regardless of thickness, will result in a large area of alopecia, given the deeper adnexal structures of the skin, such as the hair follicle, do not survive with skin graft transfer. Here's a 91-year-old man with multiple large basal cell carcinomas. In portion B, the resulting defect following excision of the lesion, and then in C is reconstruction with a split-thickness skin graft, which was utilized because of the large amount of skin that was needed. While not the most aesthetic closure, skin grafting is especially useful in the medically complex patients who cannot tolerate a more complex, long procedure. Tissue expansion is a powerful tool to increase the amount of hair-bearing scalp available for either primary closure or local flaps. It involves inserting a silastic expandable prosthesis placed below adjacent galea and gradually filling the expander in a clinical setting over the following weeks. Tissue expansion is typically indicated for patients with large defects, greater than 9 centimeters squared, and offers many advantages, including excellent color and texture match. Tissue expansion increases the amount of hair-bearing scalp while actually improving vascular supply to the expanded tissue. Tissue expanders have significant limitations, however. They should not be used in acute traumatic or contaminated wounds, as this can lead to infection and necessitate expander removal. The patient must also be carefully selected for tissue expansion, as this can be a lengthy process and time for both clinician and patient. The majority of scalp defects are best treated by replacing like tissue with like, accomplished by local flaps from adjacent scalp tissue. So-called random pattern skin flaps are not dependent on named perforator vessels, but rather on the subdermal vascular plexus, and can often provide viable local flaps for small defects. Whenever flaps are planned based on the subdermal plexus, in contrast to named perforator vessels, a more conservative flap design should be applied. As a guideline, an approximate length-width ratio of 2:1 allows an adequate vascular inflow while supporting mobility of a local flap design. Local flaps in the scalp should all be raised in the loose areolar plane, preserving galeal blood supply to the flap. Here are some simple local flap options, including a simple V to Y and advancement flap shown in A. Rotation flap schematics are shown in B, with demonstration of Burroughs triangle, which allows flap advancement without bulking adjacent tissue. Rotation flaps like the one shown here may be more useful in the scalp given the preference for broad-based flaps and present a rotational movement from donor site to defect. This patient had a large posterior scalp pilomatrixoma and was excised and enclosed with a rotation advancement flap. Local flaps based on named perforating vessels like the temporoparietal, occipital, and supraorbital arteries provide increased reliable length and adaptability in covering larger defects. By combining multiple flaps, up to 30% of the total scalp can be covered with local flaps based on known perforators. The most well-known of these combined scalping flaps is the Orticochea flap. In this technique, 3 separate flaps based on the 2 temporoparietal arteries and the combined pair of occipital arteries are raised to cover very large defects at the crown. Local techniques require the area surrounding the defect and donor tissue to be healthy, which can be a particular concern in patients with resected cancer, infection, or radiation exposure. In general, regional pedicled flaps for reconstruction of the scalp are less utilized given the long distance between the trunk and the scalp, as they remain attached to their blood supply. However, they can provide robust options for reconstruction if the immediately surrounding tissue is inadequate. For occipital defects, the trapezius flap can be utilized. The vertically patterned trapezius flap based on the transverse cervical artery perforators is most useful for closing occipital wounds and has less donor site morbidity than the transverse trapezius flap pattern, which may result in an undesirable shoulder droop. In this photograph, a 45-year-old female with a chronic occipital wound following posterior spinal fusion underwent a pedicle trapezius flap for wound closure. Seen in A is the vertically oriented left trapezius myocutaneous flap raised. In B, the trapezius flap is placed into the defect, and in C, the flap is inset and the incision is closed. In D, the patient is at a follow-up 4 weeks post-op, and you can see the flap is viable and well healed. When thinking outside the local area of tissue, microsurgical techniques can be utilized to bring distant, healthy tissue to the area requiring reconstruction. Free flaps involve tissue that is detached from its blood supply, and then the blood supply is reanastomosed to a vessel near the wound area. The ideal free flap contributes well-vascularized tissue with a pedicle of sufficient length to allow the anastomoses to be distanced from the original zone of injury. Free flap reconstruction requires advanced surgical skill but offers a viable single-stage reconstruction of large cranial defects in wounds with vascular compromise, such as those with radiation exposure, previous surgery, or infection. Here is an example of a free latissimus flap to a very large scalp defect. The latissimus muscle is removed with the blood supply, the thoracodorsal artery. The thoracodorsal artery is then anastomosed to facial vessels to restore blood flow to the flap. The skin graft is then used to cover the muscle. To conclude, here is a nice algorithm created by Desai et al. To summarize the reconstructive options we just discussed based on scalp defect size, location, history of radiation, and hairline, and the ideal reconstructive options, taking all these factors into account.